Hey, what's up guys? Welcome to InforMed with Dr. A. Today we are going to discuss about brain herniation syndrome. Have you ever bumped your head, fell down head first, or been hit on the head real hard? Usually a minor hit on the head does not lead to a grievous condition. This is because your brain is enclosed in the cranium. The cranium is a closed compartment that provides protection to the brain. Alongside the brain tissue, the other major components found within the cranium are blood and the cerebrospinal fluid. The volume of each of these components is restricted by the fixed space within the cranium and hence exists in an equilibrium. Due to the fixed nature of the cranium, an increase in volume of any one of the intracranial components will also cause an increase in pressure. If the volume of one of the components within the cranium increases, the volume of a different component must decrease to maintain this equilibrium and sustain a normal ICP. This equilibrium can be disrupted by, say, a brain mass or a massive hematoma following trauma. The initial compensatory mechanism following this are increased drainage of blood or cerebrospinal fluid from the cranial cavity, in turn allowing for space to be created for this new lesion. However, if the tumor continues to grow or the hematoma starts expanding, it will reach a certain size where these compensatory mechanisms will become exhausted, whereby no further drainage of blood or CSF will be possible. At this point, the intracranial pressure will rise to such a degree that the final cranial component, the brain parenchyma, will shift in position and become displaced. This is termed as herniation. There are different types of brain herniation syndrome that encompass a wide range of clinical features necessary to be recognized by a physician. Subfalcine herniation. Due to raised intracranial pressure, the brain under the falx cerebri herniates to the opposite side, compressing the ipsilateral anterior cerebral artery. The anterior cerebral artery supplies the motor and the sensory homunculus of the lower limb in the cerebral cortex. This causes the weakness and paresthesia of the contralateral lower limbs. However, the consciousness is spared since the brainstem reticular system is intact. Uncal herniation. When the uncus of the temporal lobe herniates through the tentorium cerebelli, it compresses the ipsilateral third nerve, the cerebral peduncle, and the posterior cerebral artery. The third nerve has an outer parasympathetic and an inner motor fiber. Hence, pupils are dilated ipsilaterally, followed by a down and out eye due to motor fiber compression. The compression of the ipsilateral cerebral peduncle produces a contralateral hemiparesis, and that of the posterior cerebral artery produces a contralateral homonymous hemianopia with macular sparing. Transtentorial herniation. There is downward displacement of the brain towards the brainstem that causes the rupture of paramedian basilar artery, leading to Durette's hemorrhage. Bilateral mid-position and fixed pupil are seen due to damage to both the parasympathetic and the sympathetic fibers of the eye. Initially, there is compression of the cortical fibers to the red nucleus, which causes the loss of inhibitory control to the red nucleus. Hence, the unopposed firing of the rubrospinal tract leads to flexure or decorticate posturing. As the herniation extends downward, compressing the red nucleus or the brainstem below, it leads to the damage of the rubrospinal tract that causes loss of excitatory stimulus to the flexures, hence extensor or decerebrate posturing occurs. This is usually fatal. Cerebellar tonsils herniation. As the cerebellar tonsils herniate through the foramen magnum, it causes compression of brainstem cardiorespiratory center. It leads to coma due to damage to reticular activating system in the brainstem, loss of all brainstem reflexes, flaccid paralysis, and cardiorespiratory arrest. These are the different types of brain herniation syndromes. Please like and subscribe for more informative video. Thank you.